I just want to tell you, so I hate acronyms. And the reason I hate acronyms, and this has nothing to do with, gun rights or anything like that, but the reason I hate acronyms is because nobody remembers acronyms. But I have an acronym for you today that I think will really help you have an approach to dizziness. Doctor, I'm dizzy. And this is an acronym that you'll never see in any textbook. This is an acronym that I've come up with 40 years of experience in seeing these patients. So this is the acronym. Whenever you see a dizzy patient, if you could think HELP, HELP. So what this stands for, so this is a way to kind of categorize dizzy patients. So the first thing is the heart. That is that people just aren't getting enough nourishment to the brain and they sort of feel dizzy. We'll talk more about that. The ears, dizziness of the ears. These people often have things like vertigo, a sudden onset of stuff, dizziness of the legs, and dizziness of the psyche. It turns out really, and this dizziness of the psyche is something that you may think what I'm going to say, but I'm not. Okay. So dizziness of the heart. And this is the kind of stuff where, you see more of this than I do. This is the kind of stuff where someone comes in, doctor, I feel lightheaded. I'm going to faint. That's going to gray out. I'm just really dizzy. And these are situations where you're just not getting a blood flow to the brain or nourishment to the brain. These are the kind of obvious things. So, they always list these things like Addison's disease. How many people ever see Addison's disease? Nobody sees Addison's disease, but anyway, so these are the kind of things. So when you see someone that comes in and says, gee whiz, I'm really dizzy, doc, I'm really lightheaded, I'm this, and you get a hemoglobin back and the hemoglobin is 5, you're thinking, you're kind of happy because you've got an answer, but it's not good for the patient maybe, but at least you have an answer. But these are the kind of things that to keep in mind. Dizziness of the heart. Now, one thing I will say is a lot of elderly folks may come in to see you, and they may have a blood pressure of 106 over 70, 104 over 62. Now, for them, that may look like a good blood pressure, but for them, they may be on 2 or 3 hypertensive medicines, and they just may be having relative hypotension. So what I do for those people that I'm suspicious of that, I tell them, get yourself a home blood pressure cuff and measure your blood pressure 2 or 3 times a day for the next couple of weeks and just see what it's running, Also, these folks are on so many medications, I'm taking gabapentin. Why are you taking gabapentin? Well, I don't know. Doctor gave it to me, never told me to stop, So think about those things. This is just a vague kind of lack of nourishment to the heart. Now, the other thing is dizziness of the ears. And this is probably, what you're really seeing at people coming in, that they suddenly get this acute vertigo, the room is spinning, they're feeling pulled or pushed to one side. And this is and I just want to show you a picture of the vestibular system. And I just want to make 2 points here. By the way, let me, here's what the vestibular, let me ask you to do this. Put your finger in front of you, and at 5 cycles per second, just do this. Go back and forth like that, 5 cycles per second, right? And what do you see? You got a blurry finger in front of you, right? Now do the same thing, but just move your head 5 cycles per second and look at your finger like that, right? And you've got a solid finger. It's not blurry anymore. Because that's what the vestibular system does. It keeps your eyes focused when your head moves. And, that's really important because it's adaptive, because, when you're looking at that, trying to shoot that, saber-toothed tiger, if that tiger's moving in space and you're following them with your eyes, you don't want a blurry tiger. You want a solid tiger. So that's what it does. It's like, have you ever seen those ice skaters and they twirl around and around and around? Do you ever wonder why they don't get dizzy? And the reason they don't get dizzy is they do something that's called spotting. And what they do is they'll pick out an object in the environment and they'll keep focused on that object. And their vestibular system will stabilize. They don't get dizzy. And if they were to close their eyes, they would fall to the ground just like you or I would. So anyway, I want you to, this is the main thing I want to make point here and make it, the divide between a peripheral vestibular system and a central. When we talk about a central, this is the brain stem here, and these are the vestibular nuclei right here, the green, the yellow, the red, the purple, and they're on each side. This is the brain stem, and these vestibular nuclei take up a lot of space with all their connections in the brain stem. So, and this is connected to the eye movements, to the cerebellum, to everything. But you could, this is the brain stem. This is what we call central. It's the central nervous system. Now, once you exit out here, this is the peripheral nervous system. These are the semicircular canals in the inner ear. And these semicircular canals come together and they form the vestibular nerve, and they meet up with the cochlear nerve, the eighth nerve, and this is the eighth nerve. And when it enters the brain stem right here, then it becomes central. But everything outside of here is peripheral. And the reason that's important is because things that are peripheral, even though they're very annoying to the patient and they get dizzy and they throw up, they're not serious. They'll get better from those. But if you have a central cause of dizziness, like a stroke, which about 20% of your strokes are in the brainstem or the cerebellum, they will affect the vestibular nuclei, but that's a serious thing. So that's the distinction that we really need to make here. So these are the main things. So when a central cause of dizziness, the main thing, the central cause of dizziness, acute vertigo, the dizziness of the ears, is a stroke. And that's the main thing you have to worry about. These other things can cause it, can cause central, but they're always associated with something else. You know, multiple sclerosis, brain tumors, they're always something else. You don't really have to worry about that. Someone comes in with acute vertigo. It's just the stroke that comes on acutely that you have to worry about. So these are the peripheral things. And I really want to make a distinction between the, now, this is one of the most common things you'll see. It's called benign positional vertigo, BPV. And what this is people will just suddenly wake up sometimes in the middle of the night and they'll turn in bed and boom, they get this acute vertigo, nausea, vomiting. It's very uncomfortable. And every time they move into that position, boom, they will get dizzy. This has to do with some of these little calcium crystals that are in the semicircular canal. Sometimes they get in the wrong place. They block things up. They throw off your vestibular system. But it's usually, this will get better usually in 2 or 3 days, maybe a week or two. But the crucial thing is they get this sudden dizziness turning in a certain position. Now, the other things in peripheral vertigo, let's see, are and I lump all these things together because you'll hear a lot of terms. And this is all peripheral. This is in the semicircular canal. They call it vestibular neuronitis, a labyrinthitis, Meniere's. And basically what we're talking about is that it's a sudden onset of vertigo, just like the benign positional vertigo, nausea, vomiting, everything else. But the vertigo is more or less constant. It will get worse if you move, but the difference is the benign positional vertigo, it will go from 0 to 60 in a second or two. And it'll last as soon as they turn into that position. Then it'll go away, you know, as they lie still. And then every time they get in the position, it'll go, but it'll go from 0 to 60. These people go from like about 40 to 60. They're dizzy all the time, but they move, it gets worse. But the reason that I want to differentiate these two is because these ones you may have to worry about a little bit more as far as ruling out a stroke, and I'll just tell you why. And the other thing is, I'm going to just mention this tumor. You don't have to worry about acoustic tumors. They don't present with acute vertigo. They present with hearing loss. But I just put that in there to put that. So these are the ears. Now, so how can you tell? Someone comes in with an acute, what we call an acute vestibular symptom. They're acutely dizzy. And you want to know, the first thing you have to ask, is this coming central? Could it be a stroke? Or is it one of these, you know, semicircular canals, peripheral things? So funnily enough, I mean, usually it's worse when it's peripheral. So the severity of the vertigo is worse, the position change makes it worse, and the nausea and vomiting is worse. That's a general rule. I'm not going to go into the nystagmus and the types of nystagmus, but here's what's really important. In general, if it's a central thing, if it's in the brain stem, you're going to get other things going wrong, not just feeling dizzy. You're going to get some tingling or numbness on one side of the body. You're going to get some clumsiness of an arm or a leg. You're going to get numbness of the face. They're going to be, because there's a lot of things going in that brainstem. So you're going to get other things associated. Whereas if it's in the peripheral, you're not going to get those things, but you may get tinnitus, like ringing in the ear, because this is peripheral. This is out in the cochlea and the semicircular canals, or you might get hearing loss. So those are the things that more sort of push it toward the peripheral and things. That's what you have to really be aware of when you talk. Do you feel numb on one side of your body? Is one side of your body weak or clumsy? That's what, of course, if they try to stand up, no matter what it is, they're going to be clumsy walking because the vestibular system is messed up. Okay, so the crucial thing is this something vertebral basilar? Is it a stroke or is it a peripheral one? And this is this can be a difficult thing, because surely if you see, okay, gosh, I got some numbness, nurse, I've got some numbness on the right arm and right leg when I'm dizzy. Well, you can sort of know, okay, I'm dealing with something that's central, that may be a stroke. But it turns out it's when you have a brainstem stroke, a lot of these people do have vertigo because those vestibular nuclei take up a lot of space. So a lot of people with a brainstem stroke in that area of the brain, which is maybe 20% of strokes, they can often have vertigo, but they often have something else. But it turns out that there are some people with cerebellar strokes that just have vertigo, and they don't have the numbness or tingling or the clumsiness of an arm and a leg. And so you could possibly miss those. If someone comes in and says, boy, I got vertigo, I'm spinning all over, it doesn't go away. It's much worse when I move, and I'm nauseous and I'm throwing up. Even if they don't have anything else, it's still possible they could be a stroke. So most folks, it's going to turn out that they're just peripheral vertigo. It's just that. But, and this is the reference for that, but you never know. And I can tell you this, when I'm called to the emergency room and I see someone and they just have vertigo, and even if they don't have anything else, they just have the vertigo, they have nausea, vomiting, I'm still going to suggest that they get an MRI scan to rule out a stroke. Of course, I practice in a place where there's a hospital, an emergency room, there's an MRI scan right next door. But, you do have to be careful that some of these people with just vertigo have this. Now, the benign positional vertigo, where they just get dizzy for, a few moments or a minute, just when they go into that position and then they're okay, that's different. I don't have to do an MRI on those, but the other ones, it's kind of, there's a little bit of worry associated with them, I realize. Now, I'm not going to go into the treatment of this, but the people, obviously, if it's a stroke, you're going to do something else. But with the vertigo, with the dizziness of the ears, with the vestibulitis, labyrinthitis, whatever you want to call it, a lot of people use the Benadryl, and it really works. It has an antihistamine, but also anticholinergic property, the Benadryl and these drugs. And, I think the problem is that sometimes people use them too long. I mean, they give them and say, okay, keep taking these things. They give them a 2-week supply, and, people suffer from the side effects of them. The dopamine blockers for nausea and vomiting, if they're having a lot of nausea and vomiting, you give them that acutely, but this is all acute treatment. Now, so we've talked about dizziness of the heart, dizziness of the ears. Remember, HELP, H-E-L-P. The most important question you can ask a dizzy patient. Think about that. What do you think is the most important question you can ask a dizzy patient? Think about that for about 5 seconds, and then I'm going to give you the answer. The answer is, are you dizzy only when you stand or walk? Are you dizzy only when you stand or walk? Because there are some people, and that's what we're talking about, is dizziness of the legs. Now, you see, there's a lot of people that will come and they're unsteady on their feet. And it may be for a lot of reasons that they're unsteady on their feet. but they don't come in, but they will interpret that as dizziness because they're walking and they feel unsteady. And they come and say, doctor, I'm dizzy. I don't know, I'm dizzy. And they don't come in and say things like, doctor, I really have a disorder of stance and gait, but I'm just going to tell you I'm dizzy. So that'll confuse you and you won't know what the hell's going on with me. So dizziness of the legs is an important cause. And the important question to ask is, are you dizzy when you stand or walk? And so this was a study that showed, so a lot of these people, this guy, they ran a dizziness clinic. And he said, anybody that comes into your office, your primary care doctor, and they say, doctor, I'm dizzy, send them to me. We're going to do a whole battery of tests. And it turns out about 60% of these people that came in and said, doctor, I'm dizzy, had dizziness of the legs. They had dizziness only when they're standing or walking. And so a lot of these people had peripheral neuropathies, because if you lose sensation in your feet and don't feel what your feet are touching the ground, you're going to be unsteady. If you have Parkinson's disease affects your balance and your walking. You may not know you have Parkinson's disease and you're just going to say, I'm just unsteady. And, doctor, I feel unsteady. I feel dizzy. But if you ask that question, are you dizzy only when you stand or walk? These are the kind of things you want to think of as dizziness of the legs. Talk about a gait apraxia. There's a lot of people, as people get older, their walking becomes wide base, slower. A lot of times grandma, of course, uses a cane and grandpa uses a walker. And that's just kind of a natural thing. It's what we're talking about is gait apraxia of the elderly, but it's just sort of getting old with your walking. But some people, that happens, earlier in life. Sometimes that happens in your 50s, just like, in any car, sometimes your transmission runs out at 30,000 instead of 50,000. So these are the people that come in and that's what they have, this just getting old kind of gait. And people say, is that what you're telling me, doc? I'm getting old? And I say, yeah, kind of, just your walking stuff is getting kind of old. I mean, some people lose their hair. Some people, skin gets wrinkled. Some people, it just affects their walking. So the other thing is, he talks about in this thing is people with multiple sensory deficits. And he saw a bunch of people who had dizziness of the legs. That is, doc, are you dizzy just mainly when you're walking and standing? Yeah, doc, I am. And a lot of these people turned out to have what he called multiple sensory deficits. In other words, they had a little bit of neuropathy, they had a little bit of cervical spondylosis causing a little bit of weakness in the legs, they had cataracts, they had loss of hearing because you need your hearing to orient you in space, and they had a little bit of apraxia. And a lot of these people had 3 or 4 of these things at once. And the question is for him was, not why are they dizzy when they're walking, but why are they walking at all? I mean, people adapt. So this is dizziness of the legs. We talked about dizziness of the heart. You're not getting enough blood flow, nourishment, maybe hypotension, whatever. Dizziness of the ears, the acute vertigo, dizziness of the ears, dizziness of the doctor, I'm dizzy, nurse, I'm dizzy. Gosh, is it mainly when you're walking and standing that you feel dizzy? Yeah, most of the time that's when it is. Then you think of these other things. And maybe you want to call in a neurology consult because that could be a problem. And of course, and I'm not saying you don't need to work these people up and get blood tests and maybe a CAT scan or something like that. So finally, that's the crucial question. Are you dizzy when you stand or walk? Okay, so now we're going to talk about dizziness of the psyche.
Dr. Abramson?
Yeah.
I had a quick question.
Sure.
If someone gets a cataract removed, is that going to improve their dizziness?
You know what? It possibly could if that was a main player. Of course, if they had bilateral cataracts, and but usually the thing is, usually these people have other things too. They may have some hearing problems, they may have a little neuropathy. Usually, so the cataract may help a little bit, but I wouldn't expect anything magical to happen.
Gotcha. That's good. Good to know.
Yeah. So let's talk about dizziness of the psyche. This is, and about 25% of people that you see with nurse, I'm dizzy, doctor, I'm dizzy, are not going to be hypotensive or anemic. They're not going to have an acute vertigo or benign positional vertigo. They're not going to have a stroke. They're not going to have a dizziness of the legs, the neuropathy or something like that. About 25%, doctor, I'm dizzy, this non-specific kind of dizziness. I'm going to dizziness of the psyche, HELP, H-E-L-P. And I am going to, this is, I think, the way that I think that this is where I can probably help you the most, because most doctors and nurses and nurse practitioners and PAs do not recognize this. What I'm going to talk to you about, you may be skeptical at first, and I'm going to go through the history of this, but I'm going to propose to you that most of these people are chronic hyperventilators. Most of them are chronic hyperventilators, the dizziness of the psyche. And what I'm talking about, this is chronic low-grade hyperventilation. They are not, if you look at them, they don't look like they're overbreathing. They don't. Maybe if you check measure their breathing, oftentimes they're breathing about 16, 18, 20 a minute, but they don't look like it. They don't feel like they're overbreathing. And the thing is, this is so common and it's overlooked. So many people miss this. So, and this is a textbook, a typical textbook, 3 paragraphs on what they call psychogenic hyperventilation. And it says hyperventilation is caused in many anxious individuals. Tingling of the hands and face may be absent, forced hyperventilation is. Now, here's what I'm going to tell you. Most of these people aren't anxious. They are not anxious people. And I'm going to, and you'll hear what I have to say. Now, this goes back. So these non-specific dizziness people, what did people call them in the past? And this traces back, most people say, to this article in 1871. This guy, Da Costa, he saw a lot of these Civil War soldiers after the war. And these were people that were on the front lines. These were backline soldiers. So it wasn't PTSD. And they had this chronic dizziness. And here's how he described them. This is 1871. The afflicted soldier got out of breath, could not keep up with his converse, was annoyed with dizziness and palpitation, with pain in the chest. His accoutrements oppressed him, and through all this, he appeared well and healthy. Shortness of breath was constantly complained of, yet it was astonishing these respirations so little hurried. Nervous manifestations concerned headache, dizziness, disturbed sleep. How many people do you see like this? This is 1871. And, these are the kind of treatments that he used. I'm going to leave that out. So, and then this was carried on. This another person evaluated and they didn't know what to call it because they didn't do blood gases at this time. This is in World War I, 1914 and 1918. So they called it was labeled neurocirculatory asthenia. This was the chronic dizzy patient. Doctor, I'm dizzy. And this is what I love this quote. And he said, and he examined these people. He said, this is one of the commonest afflictions of sedentary town dwellers. Commonest afflictions. This is back in, the 1920s that he wrote this paper. So these are the people that are chronic hyperventilators. They don't look like they're hyperventilating, but they are. This is not the teenage girl that comes into the emergency room huffing and puffing and dizzy and fainting because she broke up with her boyfriend. It's not that. It's not the attack of the vapors. This is what these people, this is what it is. They have a lot of symptoms. Fatigability, weakness. How many people do you see with these things? And a lot of times I will make the diagnosis when I first walk in the room, because when I first walk into this room, these patients will go, those big sighs. These are some of the symptoms. They go to the cardiologist to check out their chest pains. Nothing is found. Dry mouth, myalgias, all these are the things that these have. They're dizzy, but other stuff. And again, this is Da Costa's, was annoyed with dizziness. Shortness of breath was constantly complained of, yet the respirations were so little hurried. So these are the neurological things that I see. I see a lot of numbness, tingling in the arms and legs, around the ears, perioral. So when people come into me and say, I'm referred for dizziness, I've been feeling dizzy for a few months, doctor, and I got this tingling around my ears and my arms, I know what I'm dealing with. This is the dizziness plus. This is chronic hyperventilation. sometimes these things, actually, sometimes these things can be focal or pelvic. I'm not going to go with that. So chronic, how do you make the diagnosis of chronic hyperventilation? Doctor, nurse, I'm dizzy. How do you make the diagnosis? It's this constellation of symptoms. I'm dizzy, but I'm tingling all over. I'm fatigued. I can't sleep. I'm weak. I got palpitations. And of course, these people, I mean, I'm not saying you don't do a workup. Obviously, you do an EKG, you do workups and everything, but it's the constellation of symptoms. Doctor, I'm dizzy, I'm tingling, I'm this, I'm that. And then you force hyperventilation. You, in your office, you ask them to hyperventilate and you see what happens. And you rule out other things. Like I said, you've got to make sure there's nothing else going on. So forced hyperventilation. Here's what I do. First I measure the respirations. Now, when I measure the respirations, I don't tell people what I'm doing that. I check their pulse. I put my hand on their pulse and I watch their respirations for 30 seconds. And a lot of these people, even though they don't complain that they're short, that they're breathing fast, they're oftentimes breathing 18 to 20 times a minute. I have for 30 seconds, what I do is I have them forcefully hyperventilate. I go like this. Forcefully do like this. Pretend like you're blowing out your birthday candles. Go like this. Concentrate on exhaling. And I have them do that for 30 seconds. Now, a lot of these people you will find at the end of 10 seconds will suddenly get very, very dizzy. They can't go on any further. And I never tell them, I never say to them, now we're going to do this for 30 seconds. And if you feel dizzy, like you've been feeling dizzy, tell me. I don't say that. I don't want to prime them. I don't want to give them any hints. I just say, how do you feel? 30 seconds. And if they spontaneously say, oh my God, that's my dizziness. Oh my God, in 5 seconds, I can't even go on any further. Oh my God, now I start having all the tingling that I was having. That clinches the diagnosis of this hyperventilation. And so many people will have that. And then I ask them about, well, gee, you're feeling dizzy now. How about anything else come on? Anything else? And of course, it's always great to have this, to have a significant other to witness this. Because when they go home and they're going to talk to their spouse, and then the spouse is going to say, well, what did the doctor say, honey? Well, the doctor says I was breathing too fast. The doctor says, you haven't been able to go to work in 2 months, and the doctor says you're breathing. Come on. So it's great to have a witness there so you can have that person as an ally. So, I'm not going to talk too much about the physiology of this, but when you do hyperventilate on a chronic basis, there are changes chemically in your brain. There's some respiratory alkalosis, and that can do other things. But some of these people, now here's the thing. Some of these people that say, doctor, nurse, I'm dizzy. I've been dizzy for months. I got this tingling. I just feel weak and I'm not myself. I can't, my sleep is bad. I've got palpitations. I've got these chest pains. They come in and say all that, and you do the hyperventilation and it doesn't reproduce. Well, some of these people, I think the thing is that some of these people are basically kind of revved up. They're in a hyperadrenergic state. Some of them are hyperventilating chronically, but some of them are just revved up. Their brains are just revved up. And here's, this is just from Up to Date. He talks about psychiatric disorders, and he says, and even in Up to Date, I don't know whether you guys use that. It's a real good resource, but this is what a lot of doctors use. In Up to Date, these experts are saying that these patients have major depression, their anxiety, or their panic disorder. It's not the case. I've been seeing these people for 40 years. Let me tell you who these people are. They are not that, some of them are anxious, but most of them aren't. They're the type A people. They're hyperadrenergic. So here are the questions that I ask these people when they come in. They're sighing, they're dizzy for months. Do you tend to think things more serious? These are the questions I kind of ask. Are you more diligent in completing more tasks? Are you wound kind of tight? Do you worry more than most? Do you tend to overthink things? Are you more perfectionist or laid back? Are you more type A or B? Do you have a to-do list? And once that's done, you make another. Are you a to-do it now person or mañana person? Do you arrive early for appointments? Are you more impatient? Do some people accuse you of being too controlling? When you go on vacation, I'm packing like 4 days before I go on vacation. my wife, like, we're leaving in the afternoon, it's morning. Well, don't you think you ought to pack? Well, we're not leaving till 2 o'clock, it's this, but, and so if those are the kind of people these are, and I often ask, what's your spouse like? And they will often say something like, my spouse is just the opposite. I mean, I say, well, what would it be like if you married someone like yourself? We kill each other. I mean, that's kind of who these folks are. So this is the patient profile. These are these hyperadrenergic, hyperventilating. Most of them are hyperventilating, some are not. They're just revved up people. They're type A, hardworking, busy, perfectionistic, productive, controlling, high functioning, revved up, diligent, fast walking, workaholic, and they pack a week before vacation type people, and they pick life partners who are just the opposite. They may be dizzy, but they're not stupid. They pick the right partners. So here's the treatment. So one of the things I will do is when these hyperventilators, when it's clear that after 5 seconds, they really can't go on, they really get hyperventilating, they're hyperventilating. For those people, I will get them a paper, I tell them, just get yourself like a paper bag. This is too big, but at the grocery store where you put the fruit in, the grapes, and just put it over your nose and mouth. And when you're feeling really, really dizzy, just breathe slowly in there for about 30 seconds. And that way you'll breathe the carbon dioxide. And that can stop the acute attacks, the acute discomfort. I tell them, and they say, doc, you're telling me this is all in my head? I say, well, it's kind of in your head, yeah, but there's these chemicals that are going on, because when you're revved up, you have all these chemicals like, norepinephrine and adrenaline that are causing brain changes. But I reassure that there's nothing really seriously wrong. You don't have a brain tumor. You don't have a stroke. Sometimes I will use drugs like this, but not often. I don't like to use any of those drugs. These are kind of things that help people. Exercise. Remember, a lot of these people were previously exercisers. They start getting into this pattern and they stop exercising. And that's the worst thing you can do. The best thing is to go out and start exercising again, to get rid of that adrenaline, to do that. And I tell them it's not going to go away right away. It's going to stick around, but it will get better. And I'll still be here. And I tell them, look, don't try to change your personality. I mean, the world needs people like you. You need to be the mechanic for Southwest Airlines. I want you to be the way you are. I have a sign in my office. I have a sign right in my exam room, because I see so many of these people, and the sign says, if you want to get rid of your dizziness, give up being general manager of the universe. And a lot of people relate to that, because I see so many doctors, so many nurses, so many health executives with this kind of thing, productive, people. So a lot of these people are hyperventilating. And if you can reproduce the dizziness with hyperventilation, you can talk to them about this chronic low grade kind of being revved up hyperventilation type thing a lot. And I talk about how that changes your brain chemistry, acid-base chemistry, and so forth. So sometimes if they're clearly hyperventilating and it reproduces, I'll talk to them about that. I often, when they're, and I'll often add in that this is about, your whole brain engine. This is the kind of person you are. We've talked about the kind of person you are. Your brain engine is revved up. And when your brain engine is revved up, it sends out, just like any other engine, it sends out exhaust fumes. And those exhaust fumes are chemicals, brain chemicals. Those brain chemicals like adrenaline and norepinephrine, they can cause a lot of things that go funny in your, like making you dizzy or tingly or whatever. And then I say, I relate this to acid indigestion of the brain. I say, look, when I get revved up and I'm going, my brain tells my stomach to make acid, and my acid causes me to have stomach pain. So in a way, what you're having is kind of acid indigestion of the brain. That's one way you could look at it. But these kind of people, I don't tell them they're anxious. I don't tell them they're stressed. One of my colleagues has this great phrase for people like this. And instead of calling someone stressed or anxious or anything, how about this term? How do you like this? You're too passionate about life. How about that? Does that sit better than being stressed out? A lot of people prefer to be called that. Okay, so here's another explanation. It's what I call the CHFHC syndrome. None of you have ever heard of that because I'm the one that made that up. And here's what this will give you an idea of a typical patient. So one of my patients is this very cordial, very pleasant woman. She's in her 30s. She's a real go-getter. She works as a bank executive. She's married. She's got 2 kids. She was like the head cheerleader in high school, very perky woman. And she came in with all these things, the dizziness, like, the tingling, I can't do I just don't have energy anymore. Had some palpitations. So she came in with a typical syndrome. We talked about all this stuff. We talked about the personality. She comes back to see me and she says, "Doctor, I took to heart what you told me about." And when we talked about my personality and all that. And she said, "I've decided to hire a house cleaner." Now, guess what this woman did the night before the house cleaner came?
Clean.
She cleaned her house. She was up all night cleaning her house because she didn't want the house cleaner to think she had a dirty house. But that's the thing. That's who these people are. They're normal, productive, overproductive, active, conscientious people. The CHFHC, the clean house for the house cleaner syndrome. That's a lot of these people like that. I'm going to leave that one out. So when you talk to these people, here's some things here's some brushback you're going to get is like, so you're telling me it's all in my head, doc? Well, yeah, kind of. I mean, we're talking about these brain chemicals. The brain chemicals cause real things to happen. And why now? I've been like this all my life. How come it happened now? And I kind of say, well, it's kind of like the jogger that goes out and jogs 5 miles every day and everything's fine. And then one day he's out and it just blows out his knee. I mean, it's that accumulation. It's that accumulation of pressure and the pressure that they put on themselves. Why now? I mean, I'm feeling pretty good now. I mean, it didn't happen 2 months ago when my mother-in-law moved in with me. Why is it now? And I'm not sure why that happens, but it does. And I think it's sometimes the same reason why when people who have migraine, they never get migraines when they're studying for the finals or during the finals. It's afterwards when that letdown comes, because during the studying phase and the stress phase, you got the endorphins going, you got all this stuff, and it may be blocking what's going to happen. I don't know, maybe. How come it didn't happen? I took 2-week vacation in Maui. Why didn't it go away? Well, here's the thing. These people never go on vacation. They go on crusades of tourism. They make their list. Got to see this here, the Eiffel Tower, got to have dinner here, see the art museum here. It's like my kids, they would say, we went to vacation boot camp with you, Dad. That was what it was like. So they take their personality with them. Why did, you're going to get, let's see. Okay. So here's the take-home points. When you see someone with dizziness, think about these things. Heart, just not enough blood flow maybe, or maybe hypoglycemia or whatever. Congestive failure, the ears. And remember, it's important to know whether this is peripheral or central, but these are the people with acute vertigo, sudden spinning, sudden pulling, pushing to one side, dizziness of the legs. Doctor, I'm dizzy just, mainly just when I'm walking or standing up. And dizziness of the psyche. These people are revved up. A lot of them are hyperventilators, but they're not anxious, depressed, neurotic, psychotic people. They're normal people who are just revved up. Okay. Think about the mask hypotension in the elderly, those elderly people that have blood pressures of 102 over 60. Person, it still could be a stroke if it's just vertigo without all the other stuff, the tingling, the paralysis on one side, the dizziness when you stand or walk, the multisensory things. And that the psyche, it's one of the most commonest afflictions of sedentary town dwellers. And the dizziness plus, it's dizziness plus so much else. Remember all those things, the fatigue, the palpitation, the belching, the sighing, the tingling. And these are the CHFHC people. Here's a bibliography. Whoops. One more thing. So just to put things in perspective, I was many years ago, we have two sons, and when my second son was born, my older son was about 5 years old. And so it was, it was a busy time because my older son was going to kindergarten, had to be picked up and brought there and made lunch. And my younger son was a newborn. And my wife comes to me one day and she says, gosh, she says, I'm feeling so dizzy. I'm feeling just dizzy. I don't know what it is. And I get this tingling in my ears. And I'm thinking to myself, wow, I'm kind of excited by this because I think that now I can show that I can do something useful around the house. And so I explained to Pamela about hyperventilation and how the acid-base balance changes and all this stuff about the dizziness and all that. And my wife looks at me with just utter disdain. And she says, "You're telling me that my ears are tingling because I'm breathing too fast? And you call yourself a doctor?" And she turns away and she walks away and she turns back at me and she says, "Tomorrow, I'm just going to have to call my gynecologist." So the thing is, this help, H-E-L-P, it'll work. I think most of your patients can fit into one of those categories. And from there, you can take it further. But if it doesn't fit in, if it doesn't work, just send them to your gynecologist. That's, best advice. All right. We have a little time left. What I wanted to do, hold on just a second. Okay, so if we have some time, and I could, if you have any questions right now, let me hear your questions, and hopefully I'll be able to help you with those. If not, I have some case studies that we could go over that might clarify this more clearly. Any questions or?
Yes, if anybody has any questions for Dr. Abramson, please feel free to unmute yourself.
Mm-hmm. If not, I can, if not, I can just, we can still keep it open for questions, but I can, present a few kind of cases, typical cases.
Yeah, Dr. Abramson, it doesn't look like there's any questions in the chat. So yeah, go ahead and go into the cases that you would like to review. Thank you so much.
Okay. And Jessica, should we go, when do you want to stop? So that I know there's another lecture coming on.
We have an 11 o'clock stop time.
11 o'clock. Okay. So we have a few. Okay.
Yes. So excuse me.
Oh, yeah. Yes.
Oh, I'm sorry, Dr. Abramson.
Oh, would you like to see a few cases?
No, yes, we would like to see a few cases. I'm sorry, I was multitasking.
Okay. So a 35-year-old woman smoker, she's on birth control pills, family history of diabetes. She turns over in bed and gets sudden severe room spinning. The spells repeat every time she turns. They're associated with nausea and sweating. She must lie still. Spells last, I can't sort of read it, but a few minutes. When she turns on her left side, she gets very uncomfortable with room spinning and displays rotatory nystagmus otherwise. So what category would you put this in? H-E-L-P. Heart, ears, legs, psyche.
Heart.
Somebody says heart. Remember, she turns over in bed and gets this sudden spinning.
Ears, I think.
Ears, yeah, that's vertigo. She's talking about vertigo. And what do you think the diagnosis is? If this is the ears, is there anything that suggests it's in the brainstem or central? Nothing else. He's got no numbness, tingling, right? So this is probably a peripheral one. This is probably a peripheral vertigo. It's in the semicircular canals of the nerve. What do you think the diagnosis is? If it's in the ears, it's in the ears.
Is it BPV, benign positional
BPV,
vertigo?
yeah, this is BPV because, you know, it dizzy. She turns in one position, boom, she gets dizzy, goes away. Every time she gets that position. This is typical BPV. Is MRI appropriate to rule out stroke? In this case, I would say no. This is typical BPV. It goes from 0 to 60, not like 40 to 60. So that's what it is. Remember, we talked about this is peripheral vertigo. It's in these semicircular canals here. So this is not a serious type of vertigo because it's not in the brain stem. This is central. This is peripheral. Okay. And this is the benign positional vertigo. These are the things that are also benign. Call them different things. So benign, it's sudden onset positional vertigo, lasts seconds to minute, but recurs whenever the position is assumed. Okay, and this is, you can, in physical therapy, you can send people and they can get this kind of treatment for it, this exercise I give. This is a sheet I give people to exercise at home, but it will go away. Okay, all right, 85-year-old man complains of chronic dizziness for months. When asked to describe dizziness, says, "It's just dizzy, doctor." When you ask if it's room spinning or vertigo, he nods agreeable. "Yeah, that too, doc." Exam shows moderate loss of sensation to position in the toes. His gait is broad-based, somewhat unsteady. As a hearing aid, noted to have bilateral cataracts. Last month, another clinician ordered an MRI, and it showed really just the typical thing, just normal stuff. Excuse me. So what is the most important question to ask him about his dizziness?
Dizziness when standing.
Yeah, does this dizziness just happen when he's standing and walking? And if he answers yes, what category of help is that?
Legs.
Dizziness of the legs. And if you put him in that category, what is the diagnosis?
Neuropathy, peripheral neuropathy. No?
Yeah, probably neuropathy, probably maybe a multisensory deficit, because only when this is a question to ask. Heart, ears, legs, he's got legs. And some of these people he has a neuropathy, but he also has cataracts, loss of hearing, neuropathy. So he's probably got, neuropathy, multiple sensory deficit type things that would cause his problem. But the main thing is he's dizzy only when he stands or walks. That's the crucial question. Oops. Okay. Okay. A 65-year-old Jamaican man with sudden onset of what he calls giddiness. You ask him if he's lightheaded or is he vertiginous, and he insists he's giddy. I trained in New York, in Brooklyn. We had a lot of people from Jamaica there, and that's what they would say. They would always say it's giddy, doctor. And he admits some ringing in the left ear. Symptoms have been constant without relief. He must lie perfectly still. Had something like this about 4 years ago and lasted 3 days. So this guy has sort of acute, what he's trying to, he's really has the nausea, vomiting, and room spinning. So what category of help would this be? Is it a heart? Is it the ears, legs, or psyche?
Ears.
Ears, yeah. And central or peripheral? What makes you think this might be? Well, I mean, first of all, what is there anything that suggests it's central? I mean, he doesn't have any tingling one side of the body, focal paralysis, weakness, or anything. But he has ringing in the ears, right? So that would all suggest that this is peripheral. And this guy, ears, he's got dizziness of the ears. Remember, it's peripheral is more, if they have tinnitus, hearing loss, it's much likely to be more peripheral, and that's, more, and that's a more benign thing. Okay. Let's say 45-year-old man, American Airlines supervisor of mechanic, has 3 months of dizziness, 3 months of dizziness on and off. Can last minutes to hours, occurs almost daily, any position. During this time can function, but feels impairs. He also has some chest tightness, occasionally gets lump in the throat, has some fatigability. He's given up coaching his son's doctor, no longer does his gym workout, has some intermittent tingling of his lips and ears. Sometimes the tingling and things can occur with the dizziness, but sometimes independently. Numerous doctor visits, negative exam, full cardiac workup, negative, everything, MRI was negative. What category of help would you suspect?
Psyche.
Psyche, dizziness of the psyche. What's the test you're going to do in your office at this point?
The hypoventilation.
Do forced hyperventilation, 30 seconds. Just have him breathe. And boy, if he starts really getting decompensating, after 10, 15 seconds, you know what you're dealing with. So this is dizziness of the psyche. Hyperventilation. I measure the respiration, 30 seconds. How do you feel? I don't tell them what they're going to feel like. Does it reproduce other symptoms? Hey, does the tingling, if he mentions, yeah, God, now I'm starting to tingle too. It's chronic, it's low grade, it's common, and it's often overlooked. So this is the dizziness plus syndrome. Remember all these things that people have along with dizziness. It's the constellation of symptoms. Forced hyperventilation will reproduce it, and you have to rule out, of course, other diseases. That's just. Okay, so he's a 68-year-old man. He, whoops, okay. 68-year-old man never comes to the doctor, sudden onset of being forcefully pulled to the left with some room spinning. So a lot of people with vertigo, they may not describe room spinning or vertigo. They may just say, I'm being pushed or pulled one way. And that's sort of the same thing. He had some nausea, but no vomiting. Had to lay down on exam, his vital signs, but his blood pressure was a little high. And he said he might have some numbness or tingling on the left side of his body and the right side of his face. He had vertigo. There seemed to be some mild ataxia of the left arm. So he was clumsy in one arm. So what category of help? He came in with dizziness. What category of help do you think this is?
Heart.
Well, remember, he says he's being pulled to the left. Room was spinning, right?
Ears.
Ears, yeah, that's kind of like an ear thing. And would you think this is central or peripheral?
Central.
Central. Why central?
Because of the type of nystagmus he's having and kind of the ataxia,
Yeah.
other focal symptoms.
And the numbness and tingling, left body, right face. Yeah. So you got to have to, this guy's going to need this guy. And this is what you can see the MRI scan right here. He's had a brainstem stroke. This is the brainstem. This is cerebellum. He's had a brainstem stroke there. Okay. How about this one? Has been healthy, but had what he calls dizziness off and on for 6 months. He admits to you it mainly occurred when he walks. The workup and everything, cardiac MRI was all negative. And he also admits to you that his handwriting has been smaller the past 3 or 4 months. So what category of help is this?
Legs.
Legs. What do you make of the symptom of the small handwriting?
Possibly Parkinson's.
Parkinson's, that's right. That's a very common symptoms of Parkinson's. So this is dizziness of the leg. What he described as micrographia, very characteristic of Parkinson's. He has a mild rest tremor when you examine him, narrow base gait, smiles kind of frozen. So he came in saying, Doctor, nurse, I'm dizzy. but it was really a dizziness of the walk, dizziness of stance and gait. So it's all in that category. Now you may, as nurse practitioners, you may not, I mean, you may not be able to figure out what exactly it is, but at least if you could say, this is dizziness of the legs, it's somewhere, something's wrong, but it's, and maybe I need a neurologist to see him, but at least you have an idea where this is going. Okay, let's do this last. Okay, boy, I shouldn't have, this is too long, but okay, healthy, no meds, 3 kids, admits to being a tiger mom, bank executive, doubles. She's a go-getter, friends is a control freak, 6 months of dizziness, last minutes to hours, more fatigued, intermittent paresthesias of the arms and legs, everything's negative. She sees several neurologists. Everything's okay, but she hasn't got a firm diagnosis. They could not tell her for sure what it was. She is worried that she might have something like a stroke, like her dad had. You do a test in the office that none of these previous doctors have done. What's the test?
Forced hypoventilation.
Forced hyperventilation. And within 10 seconds, she became dizzy, noted again the tingling of the left arm and leg, but also around the mouth, and felt like she would pass out. How do you explain, to her the diagnosis that might be acceptable to her? That's a hard one. That's hard. But, like I say, I talk about, the hyperventilation that, and I always talk about that in the context, of the personality type. Wow, you are just you're too passionate about life. You're revved up. You're on the go. The brain is your brain engine is overactive. It's sending out exhaust fumes. Those exhaust fumes are chemicals, and those chemicals can make you feel dizzy and fatigued and tingly and everything else. That's what's going on. You're revved up. It's, that's how I try to explain to these people. You're too passionate about life, but don't change your personality, because we need bank executives like you and tiger moms, because that's what's going to make a better generation, maybe. Wow. Okay. It's, I had some other cases too that I hope might clarify this, but I hope you've gotten just some ideas about this, about dizziness, about the approach. When you see a dizzy patient, think about putting them in one of these categories. Help. And this is the kind of the lightheaded person, that feels faint and so forth. And maybe they're anemic, maybe they're hypotensive, whatever. Maybe they're elderly and just too much medication. So think about those. Think about the ears, the sudden vertigo. Think about dizziness of the legs. They're only dizzy when they stand or walk. And dizziness of the psyche. Again, these are a lot of revved up people. A lot of them are hyperventilators, and you can prove it to them and show them. And a lot of times that will bring them reassurance. So anyway, thank you so much for allowing me to share this, this experience, my experience with you. I really appreciate talking with you guys. You guys are doing great work.
Thank you so much, Dr. Abramson, for sharing your knowledge and expertise with everyone. It was a wonderful presentation. Dr. Abramson is available on our VC platform. If you guys in the future ever need to tap into the MAVEN Project or ever have the opportunity to do so, he's available and can receive e-consults or is available to receive consults questions. Again, thank you, Dr. Abramson, for your time. This was a wonderful presentation. We will begin part 2 of today's didactic at 11:05. That topic will be caring for patients with chronic mental illness with Dr. Charles Schwartz. So we'll see you in about 4 minutes, everyone.
Okay, thanks so much, Sharice. We had some trouble with technically, and you got us through it, you and Jonathan. So appreciate it. Thank you so much.
Of course, we'll always
Thank you,
hear from
Dr.
you.
Abramson.
Yeah, and thank you, Jessica, for organizing this, and go Georgia Bulldogs. I'm sorry, folks.
Oh no.
I
So
love my Bulldogs.
we're in Alabama. We got some Auburn fans. We got some Alabama fans. We got all the things. So
We have a Georgia grad, just so you know, so go Dogs.
yeah, Trey's got to
it.
speak up.
All
No
right.
dogs.
Okay, all right. You got some good people there then.
Well, thank you again. We hope you have a great weekend.
All right. Bye-bye.
So hello, hi, I'm Charlie Schwartz. Just want to say hi to the departing faculty people. I caught the tail end. It was quite nice.
Hey, Dr. Schwartz, we'll look forward to hearing from you real soon.
Absolutely.
How you doing, Dr. Schwartz? How's everything? Nice to see you.
So I could,
Wait, who's sharing their, oh, I think that's Dr. Oops, let's
That's me.
stop sharing your
That's-
screen, Dr. Abramson. Oops. Oh, Dr. Abramson, I think.
Yeah,
Let me disconnect you.
yeah, okay. Oh, wait a minute, I got it. I think I got it.
All right, perfect. Awesome. And Dr. Schwartz, and Dr. Abramson, feel free to stay on if you'd like. Dr. Schwartz, if you want to start sharing your screen just so that we're set up and ready to rock and roll.
so I have my screen. I mean, the presentation's across the desktop screen. I'm not seeing. I don't. A little
So,
rusty. I'm
go
not
back
seeing
into
the
the
screen
Zoom.
share.
Actually, let me
Go back
give
to-
you,
Oh, so here's Zoom.
co-host.
Okay, here's I see screen share.
Yep, now I made you the co-host, so now you should have the ability to share your screen. If you just hover at the bottom of your screen, there's a green button. It says share screen. If you click on that and press share, should be good to go. So are you in the Zoom meeting?
Yeah, and I just
So,
it says desktop one is a possibility. I have the presentation on the desktop behind the screen. Not quite sure.
what's the first option that you see? Does it say desktop one?
Yes.
Okay, try that and then try clicking share.
Okay.
Oh, wonderful. All right, perfect.
Okay. And then like slideshow.
Yep. Perfect. Wonderful.
Perfect.
And Dr. Schwartz, I remember we connected a couple months ago, but do you want me to go through your bio? Do you want to introduce yourself? I know you presented to the Stanford team before, but it's totally up to you. I can do a nice formal
Yeah,
introduction.
you're welcome to do it.
Okay.
I would be grateful for you to do it.
All right, wonderful. So we'll get started since it is now 11:06. Again, same spiel. If you have any questions during the presentation, please submit them into the chat box below, and we'll review them during our Q&A session. And we also encourage that attendees turn on their cameras if possible to help increase engagement during today's session. Again, this session is being recorded. So welcome back everyone for the second half of today's didactic session on caring for patients with chronic mental illness in primary care with Dr. Charles Schwartz. Dr. Schwartz is an internist and psychiatrist with a deep and long-standing interest and experience in high-quality, integrated, and collaborative medical behavioral care for patients. His goal is to focus on achieving clinically important medical and behavioral outcomes that can be measured and tracked. Dr. Schwartz spent his career at the Albert Einstein College of Medicine as an associate professor of medicine and psychiatry, and the Montefiore Medical Center as an attending physician in psychiatry and internal medicine, as an attending physician in psychiatry. He is currently interested in remote and telephonic work that allows him to actively participate in care programs that utilize interdisciplinary care teams in primary care medical systems, as well as in special need populations such as addiction, HIV, chronic mental illness, and homeless medical care. Dr. Schwartz, sorry for butchering your bio a little bit, but you may begin whenever you are ready.
Okay, so so just to say, I guess probably the three departments I spent most time in were internal medicine, social and family medicine, and psychiatry. Along the way, I somehow was adopted as an honorary family medicine doctor, and was the chair and I would joke about that, but I joined their faculty except for pediatrics and obstetrics. I covered all the basics. But in any case, let me see if I can get rid of this. Okay. So the talk is about caring for patients with chronic mental illness in primary care. Okay, so I want us to be able to define the role of the primary care physician in the care of the mentally ill. There are patients who are in specialty mental health care. And then there are patients with chronic mental illness who aren't getting any mental health care. And then trying to understand how to integrate their care with primary care, understand the concept of the specialty medical home. So what I mean by that is that our general idea is if we're going to do integrated comprehensive care, the idea is to do that in a medical, patient-centered medical home, like a large ambulatory setting that's in medicine or family medicine. And that everything is brought to bear under that, in that setting, if they have mental health needs, if they have specialty needs and so on, that they don't get sent 14 places and their care isn't fragmented and people hopefully speak with each other on the team so that it's smooth, coordinated, and not fragmented. There's another model, which is called the specialty medical home, where patients may be extremely well connected to a specific disease-centered program. For instance, they may be very well connected in a chronic mental health clinic, a community mental health center, and they may not really have care outside of that setting, but they actually go and are connected. Or it could be a dialysis program, or it could be an HIV Ryan White program. So there are a variety of specialty programs, or I suppose it could be post-cardiac transplant or something like that, where all the care is, the person has frequent contact with caregivers in that specialty program, and it's optimal to bring other kinds of care to that setting. Classic example, when I was a medical resident, people would be on hemodialysis 3 times a week. I would be in primary care clinic. Once in a while, they'd be referred over because they needed some health maintenance thing or a flu shot or something. And I found it really an anathema as to why that was happening. After all, was not the nephrologist an MD? And did they not have multiple staff at the dialysis center where the patient was spending as much as 3/7 of their lives every week? Why did they have to get sent to somebody else to get a flu shot? The other interesting thing there was that if I was going to be their primary care physician, I might want to draw a blood test, but actually patients with shunts access for hemodialysis, people aren't supposed to draw blood tests except the people with the expertise in the dialysis center. So I could give a flu shot. I couldn't do a blood test. And why were they doing this in the first place? The patient was already spending 3 times a week in a intensive medical setting. And here we were dragging them to a 4th or a 5th. So that would be called specialty care, where everything ideally would be organized around the principal care, the care that people are actually attached to and getting. I'm going to throw out some vignettes. Actually, I'm more interested in things you've run into that you think about over the course of the next 2 minutes that you'd like to bring up for discussion, examples of what you've seen that seemed like it was high quality integrated care, things where there were problems. And just to say, there are 2 handouts, maybe 3 handouts, that you should be getting in conjunction with this. So in terms of integrated care, the concept really is a critical concept because there's been a myriad of high quality evidence-based research that shows that primary care is the hidden mental health network, both in the United States and worldwide. What I mean by that is the majority of patients with behavioral health problems get their treatment by primary care physicians. And we also know that the majority of primary care visits involve one behavioral issue or another, and that could be including things that sound very medical, like difficulties with adherence to the treatment, struggles to cope with the treatment, struggles to cope with the implications and adverse effects of the illness. So there's a lot of counseling and there's a lot of behavioral and psychological issues involved in primary care. And not to mention when somebody might have a more narrowly defined mental health problem, the place the vast majority of people go to primary care for that. Primary care physicians like yourselves generally went into this, or what they've been taught or would like to do is treat people with medical illnesses or health maintenance or screening, and maybe to treat people with perhaps what might be called garden variety mental health issues that crop up, a patient struggling with some anxiety or depression, but they're not really. Most people are not trained to feel that they're going to take on people with serious and persisting mental illness, chronic schizophrenia, and so on. And that's unfortunate, since all of those people may go to primary care for their care for everything, including their schizophrenia, and may not have access or may not choose to access mental health care. And the mentally ill desperately need high quality medical care. I don't know if you're aware of this, there's startling evidence that's done on multiple large studies that show that patients with chronic mental illness die 15 to 25 years younger than those in the general population. And if you're chronically homeless, your longevity is 30 years less than the general population. So these patients are very sick. Oh, by the way, most of the deaths are medical deaths, not suicide or drug overdoses or things of that nature. So people are just not getting medical care. So in dividing the patients who have chronic mental illness and are seeing you in primary care, I divide them into 2 groups. One group is, in addition to being attached to the primary care program, is also getting regular care and has connections with a chronic mental illness program. For those patients that have both of those things, my conclusion is for you that this is a gift, and especially if you use it well, that they're getting all this care and it's not all on you. And the requirements to use it well are to communicate and collaborate with the mental health provider, establish clear roles for the primary care and mental health providers. The first thing in very devastated patients is to address food, clothing, and shelter. No one can focus on medical or mental health care when they're hungry and have no roof over their heads. Unfortunately, there are a lot of patients that you are seeing now and will see, who have serious mental health problems, but are not receiving any kind of mental health care, and they are just coming to primary care. And that's difficult because you're on your own. So the first one is, what did I say? So the previous case is a gift. This one, I would say, good luck. And the only way to really approach it is to go slow and establish rapport, therapeutic alliance, start where your patient's at with what concerns them, express your concerns, try to see that there are frequent short visits. And I think it's important, although we've fallen away from this, that actually touching your patient every time in some physicianly manner is a critical intervention, very powerful. Previously it's been called laying on of hands, but even if you don't feel you absolutely need to do a physical exam, to take their blood pressure, listen to their heart, something, so that that becomes a ceremony that has very powerful impact on their feeling connected to you and connected to that setting and feeling like you're taking care of them. And initial and periodic alcohol and drug screening are critical. I think they're critical for all patients, but in particular for patients who seem to have some kind of behavioral or mental health difficulties, because it can always be alcohol and drugs in whole or part. And the other person, in addition to collaborating between the primary care doctor, yourself, and whoever it is that's treating the person in mental health, collaborating with the family and the core significant others is really quite critical. Although I wasn't trained as a family medicine doctor, later on, of course, I became a faculty member in family medicine and was grandfathered in, so to speak. But I have a strong feeling that all medicine should really be family medicine. That is, that involving family members and significant others, they can provide tremendous additional diagnostic information about what's going on with the patient. They can flesh out more history. And also you bring them on board as the treatment team so that they understand what the plan is, whether it's some medicine 3 times a day or much more elaborate or multiple components. And when they come, and they can help the patient do it, because they have been given a heads up that these are the critical elements that are important to help this patient become more well and functional. And then when the patient comes back, they can tell you how successful it's been. All of this with the family, I would say, is really, it's kind of logical, but we don't think about it so often. When the organ of observation is the organ that's impaired, that is when somebody has a mental problem of one sort or another, it's not realistic to expect that impaired organ should be a terrific reporter of what's going on, and particularly objective. It's an unfair request also, but we tend to do that. We only want to know from the patient how they're doing. And I think that's unfair to the patient, and also it doesn't yield the most high quality information. So I think families are critical. I'm just going to give you one example of a patient that has issues in this area. A 40-year-old patient comes for first primary care visit with a history of stable chronic psychotic disorder on an antipsychotic. The medication was previously provided by a PCP who has moved to another state. The patient tells you he went to another PCP at another clinic who refused to write any prescriptions for his medication and told him, "I don't do that, you need to go see a psychiatrist." The patient no longer has a doctor of any kind now, and he wants a new primary care doctor to be my doctor, continue my medications, take care of me if I get sick with something. I don't want to go to a psychiatrist. So I wanted to open this up for a minute. Has anyone faced people who want you to manage their, say, chronic antipsychotics or other medicines of that nature, or who are not seeing a psychiatrist?
anybody has a response, please feel free to unmute yourself, or that would be great.
When I worked in a clinic in West Virginia that had a lot of homeless patients. And because of the transient nature of their care, they would often come to this clinic because they kind of resided at the clinic. They would hang out there all day. So instead of going to a mental health provider, they would say, hey, can you refill this medication? And I'd say, something like temporarily or something like that, if I could get records, and then I'd want to send them back, and they still wouldn't go back to their mental health provider. So it was this like cyclical challenge of trying to get them into a mental health provider if I did provide that medication. But the alternative was like, are they just going to be on the street without medication? So it was just a real tension. One productive thing we did was get a psychiatrist to see a patient periodically, and then we would give her an injection of an antipsychotic, and that helped sort of like prolong her visits with the psychiatrist, and then we could provide the medication at the clinic. So that was something that I felt like actually worked for her, but I don't know if that works for every patient. So yeah, that can be very challenging and feel very high risk for a primary care provider.
Okay, that's a good, thank you so much. What you said was a very rich set of ideas and approaches. And I want to congratulate you. If I want to sort of put it in kind of a framework, I have a hard time not putting things in academic frameworks, but in any case, so that first of all, this is a patient who is connected to the primary care program. Already that's a gift, because for the patient to be connected with the healthcare system anywhere in a way where they are repeatedly there, hanging around, seem to have some good feelings about that setting, that's half the game right there, because so many patients are not connected to anything. And it gives you the basis for doing things. So of course you inquire, you get to know the patient, you inquire if they would be willing, or that you are aware of a mental health provider or clinic that's nearby and accessible. And it would seem natural that it would be terrific for them to go there and get those problems addressed and come back to you in primary care. Speaking of which, none of the strategies are getting rid of the patient. And you have to reassure your patients about that. If you're going to refer them to a colleague about something, or another institution, I want you to go there, and then I want you to come back because I'm your doctor. Because sort of turfing people out and making a lateral pass and have them never come back again, the patients always wonder, those with mental illness, if we really like them. And it's a fair question. Of course, our job isn't to like them, our job is to care for them. But but that if we're uncomfortable, then we just assume find ways of not caring for them. So mental health, and come back to me. And then also I sort of know that person, or I've talked to them, and I will talk to them about your care after you see them. So bringing it into an integrated care model. So, however, there are patients like the ones you described that either don't want to go to a mental health clinic for their chronic mental health treatment, and it's been pretty firmly established that they need significant treatment like antipsychotics or what have you. And so then they're your babies, and that's okay, because you have, well, in medicine, the classic thing is stated is you have to start where the patient is. And then hopefully over some period of time, as you and they get to know each other and develop an alliance, you may eventually bring them over to your side of the page. Like blood pressure isn't just because you get upset, or you don't take a pill when you feel uncomfortable because your spouse upset you or something for your blood pressure, and you feel a little flushed. So the health belief systems, but you gradually try to work with them over time. You can't immediately plunk them out from their belief systems or their approaches to where you'd like them to be. So it's a longitudinal process. Of course, that is always what I liked about primary care, is it's longitudinal care. And of course, I know what you said, that homeless people may be in and out and maybe in different places and so on. So that's a more challenging population to try to apply that model. But anyway, so to take, I should say psychiatric medications are not complicated. I often wanted to write a companion book to other books, would be called a psychiatric medication for dummies. Now the dummies include the psychiatrist, by the way. I'm allowed to say that because I'm a psychiatrist. It's not complicated. Medical medications like step care for diabetes and so many other things, or HIV care, or so many other things are very complicated in terms of their multiple pharmacologies and how you approach them. Psychiatric medications are really pretty easy, although people are frightened about getting involved with them. But that shouldn't ought to be on account that you don't have the skills to do it. So if they've been on something and they make a good case that it's been helpful, that would certainly be the place to start. But with frequent visits and seeing if they're right, if this particular medication makes a profound difference, and to have some time frame to evaluate that, because I believe that there are really no diagnoses in medicine and no treatments. There are only provisional diagnoses, which you see if they're true over time, and therapeutic trials where you try something and you're not committed to it for the rest of the patient's life, but in some time frame, you and the patient and family judge whether this was really effective or not. And hopefully, if it isn't effective, the patient might possibly be willing to try something else. But anyway, to undertake it, start where the patient is, see them frequently. Obviously, start slow and start low and go slow. And then the last element you mentioned is the psychiatric consult. So now we're starting to talk about integrated care, about, I don't know if it was actually bringing a psychiatrist to your setting, or for the person to see a psychiatrist, but only on a consultative basis nearby, and bring that information in. But that should be the basic model. The basic doctor should be the primary care doctor for all medical and behavioral problems that their patients have, and they should get the input and guidance that they need. But the 19 specialists shouldn't be the ones providing. So, but your case is a great case because it comes to that conclusion that you are, although you didn't necessarily want to, you are the treater for that patient. Patient's connected to you, but you have the guidance periodically of somebody with greater expertise in the medications and all that. I'm just going to give you one other one. So I trained 50 medicine, social medicine, family medicine, primary care medicine residents a year for 30 years. So I guess that amounted to an awful lot of residents who are sprinkled throughout the New York, the Northeast, and elsewhere, and run a lot of things. I never like to run things, so I inevitably, very happily, would come to work for my former residents, which I enjoyed no end. But anyway, former primary care resident mine calls. She's 6 months out of her residency, working in a medical clinic in the Bronx, and she tells me something to the effect, say hi and whatnot, but she knows she can call me if she has a question. And she says, I'm very grateful you taught us how to manage depression in our patients and anxiety, but now I actually have patients with schizophrenia. They're mine. They're not going anywhere. And you had taught us that specialty illnesses at the level of severe schizophrenia and bipolar disorder were not really primary care treatable illnesses, and they really needed to be treated in a mental health psychiatric setting, and that it was only more garden variety, or what some people call incidental users of mental health services. That we should get very good at doing that in primary care. But I have a problem because now I have a whole group of schizophrenic patients, and they expect me to treat them, and how will I do that? A parallel thing is when I was president of something called the Association of Medicine and Psychiatry, which was a national integrated care organization for internists, psychiatrists, family medicine psychiatrists, and triple board child psychiatrists. For our national meeting, I invited a pulmonologist who's the West Coast governor of the American College of Physicians, which is the national internist organization, to give a keynote address on what internists need from psychiatry. Like the resident I just told you about, I had no idea what he was going to say. I probably should have asked him to send his remarks in advance, so I had a heads up. But he said, "I need you guys to teach me how to treat my bipolar patients." So this is a professor of pulmonology at an academic medical center on the West Coast, and in his practice, he's being expected to field, manage, treat, diagnose, etc. patients with very severe mental illness, and he was never trained to do that. And his preference would be to treat pulmonary problems. So what do you think about the primary care resident who now finds him or herself having to treat severe mentally ill people, or even the faculty member who's a super subspecialist in academic medicine, but in their practice, somehow their insurance providers or their institutional structure expects them to treat people who come through into their practice? Any thoughts? As you should say, it's an extension or another similar question to the last one that I'm sorry I didn't get the name of the person, but that you so wonderfully fielded about the homeless patients coming in who are aware that they have mental health problems and have had treatments that they think might have been helpful, and they're asking you to give them to them. Would you be comfortable doing that?
No.
Okay, fair enough. I think up front, no, because it's not the frame of reference that you're trained to work within. And specifically, you may not be taught about those kind of problems or treatments, maybe in some general way in the first 2 years of medical school or something, but not about learning how to treat them in the way that you learn how to treat hypertension, diabetes, heart disease, HIV, etc. And also, well, to take on something that you don't feel expert at is very uncomfortable, and also, frankly, the mind is kind of scary. If you touch the patient, is there a schizococcus, and might you not get it as an infectious disease? That was always a joke we talked about, but there's some truth to it, and patients can be hard to treat because they may not interact with you in the way that patients do. They're distracted, or may be having psychotic experiences, or maybe disorganized, or maybe terribly slowed down by depression and unable to focus, or maybe agitated and all over the place. So it's very challenging and somewhat in an off-putting population to primary care folks, understandably so. So it's a daunting thing, but I'm suggesting that particularly if you have some backup, somebody who is more senior to you, who is a medical or primary care or what have you, family medicine physician who has more comfort with this, or if your setting has the capacity to ask questions to mental health experts to guide you. Okay, so the last thing I just want to mention, to try to organize kind of collaborative integrated care, because the ideal would be for people to be treated both in the mental health setting for their very severe mental health problems, and also have a medical doctor. You get a call from a psychiatrist in a local clinic asking for help. It's a 38-year-old patient that comes to psych clinic for psych visits, medications, groups, individual follow-up, case management. So again, just one thing is this patient's well plugged into that place, and that's really a gift because so many patients are not. And if they are, then that can be used to the patient's benefit in many ways. The patient told him that he has some history of pressure, maybe other things, that he refuses to go to a primary care clinic. So this is not your world. This is the other world. This is where the person's in the mental health setting, but seems to have medical problems. And so you may not really be able to, this is not your experience, you may not be able to kind of approach this issue. Well, first of all, when people are psychiatrists, they seem to have this MD attached to their name. And then they seem to give medications that make people, that hopefully help people be better, but also have high potential to make them terribly medically ill with metabolic syndrome, et cetera, et cetera. And that's their responsibility. They thought they were trained in psychiatrists to do therapy. Well, they don't get trained that way anymore, but to diagnose discrete severe mental health illnesses and prescribe the medications that are the state of the art, such as it is, medications that are linked to those diagnoses, and that's their job. But they sometimes do not seem to understand that if they're going to give olanzapine or quetiapine or a mood stabilizer, that those have medical consequences and that there are protocols for monitoring them, and that things, and they don't do that. And so that's very problematic. So one thing is psychiatrists in chronic mental health settings really need to step up to the plate. They don't have to do everything, but they have to have an awareness of what the implications, and that the person is also a person who can get medically ill, and that everything is not about the mental health problem. And when they get medically ill, somebody else has to help really get them the care they need, whether it is provided by the MD psychiatrist or whether the outpatient mental health clinic MD psychiatrist take real responsibility for making sure the patients get care and closing the loop on that. So what I've just told you about patients saying they have medical problems in a mental health setting, I think that's the rule and not the exception. But the rule and not the exception is that nobody pays any attention to it. Okay, so this is the next level up from what I said. Not only is the patient connected in a mental health setting, which is wonderful, and they have some attachment and they attend. They also have a primary care physician, and they actually are attached and attend regularly in primary care clinic. The only problem is how the patient uses those two arenas. So this particular patient, chronic mental illness, most of the time when she comes for primary care visits, she complains of hearing voices, someone telling me to kill myself. And you and your nurses in primary care are going crazy. You get very nervous. What are you supposed to do with this person when they come in and they tell you they're hearing voices telling them to kill themselves or whatever it is they tell you? And you do the best you can, and you tell the patient they'd best go to the psych clinic or the ER. And one huge downside is they're actually there because they have medical problems. But when they say something like, voices are telling me to kill myself, all of a sudden that becomes the sole focus. And I'm not saying that that's incorrect, but in the long run, they're not getting their medical problems attended to, and then they fall into that group that has a 30-year lower life expectancy than the general population because they don't get medical care, even though they're coming. So this particular patient also has a connection to the mental health program. And yesterday, her psychiatrist called asking to speak to you. We don't know what to do. When she comes in, she tells her therapist she's having chest pain. Everybody gets upset and scared, and we don't know what to do. It completely derails our psychiatric care, and I have told her to go to the clinic and see you. I assume she's telling you about the chest pain and you're working on it. So the bizarre thing that happens not at all infrequently is the patients present their medical problems to their mental health providers and their mental health problems to their primary care providers. And they get no care because everybody is so thrown by things that are quite serious, like is this person having an MI, or is this person having a life-threatening psychotic break and life-threatening suicidality, and they don't get, so in the medical setting, they don't get the medical care, and in the psychiatric setting, they actually don't get psych care because everybody's worried about the MI. So collaborative care, it's critical that when patients are in both settings and they're your patient, that it's important for your staff, whoever, to be in touch and have established communication with the mental health provider on the other end, and regular communication. So number one, there's this sort of thing where there seem to be issues on the table that are being misdirected and do need to be addressed in a way that's effective so that they allow for the addressing of other things as well. But there are other aspects to this. For example, it would be very helpful for you as a primary care provider, with the help of your colleague in mental health, to know if the patient is stable, what are the early signs of relapse, and what do they look like? And so that, because you may have more visits at times than the mental health people have with the patients. So if the early signs of psychotic break is a change in the way they dress, or they shave off part of their hair, or comb their hair the opposite way, or whatever it might be, it's very non-specific. You can't find it in a book. But over time, families and mental health providers come to have some ideas about what it looks like when somebody who looks like they're doing pretty well but has a recurrent mental illness starts to fall off the edge. And the earlier you identify, the less of a catastrophe it is. For example, they may not need to be hospitalized, or it may not need to find themselves on the street. They may be able to be aided in getting care to nip it in the bud. Could be something like they have stopped taking their medications, or it could be many other issues, because medications unfortunately only are as effective as they are. But early identification is another feature. And conversely, what should the mental health provider do? Because in those interim visits, if they've been treating for blood pressure, why not take a blood pressure? And then you have more data points on how the person's doing, or a finger stick if you're doing finger sticks, if it's insulin-dependent diabetes, or whatever the case may be. So you may be able to provide interim things that, because you have additional points of contact with the patient. So it is now 11:46. Let's see. Okay, I'm just going to tell you briefly about this fascinating patient who I got involved with when he was at Bellevue. He's a 39-year-old man with end-stage renal disease, severe chronic mental illness, also polysubstance abuse, and also homelessness. And he has no connection to any outpatient dialysis center. So he comes in uremic. He has a several-week hospitalization until they can, get him back to normal metabolic milieu parameters, and then he's discharged to nothing because he doesn't have a program. And also he's been uncooperative with any approach to housing, and of course housing's a whole catastrophic issue anyway. Boy, do we do badly about that across the country, about having available housing for poor and impaired patients, and that's a real issue. I should say, if you want to be political about it, look to the real estate industry as to a big reason why that's not available. But in any case, he comes in for uremia, is near death's door every time, is in the hospital for several weeks, is discharged, disappears out into the New York community. God knows where he's staying, on the street or whatever he's doing. He doesn't come back for any care of any kind, neither mental health nor nephrology care. And then a few weeks later, he ends up in the ER again in life-threatening uremia, and the cycle starts again. at the level I got involved with him, he was actually on a med psych unit at Bellevue. He had been admitted to the medical service because he had life-threatening uremia. But as they got to know him better, and as he became somewhat more metabolically normal, his head cleared enough so that he was communicating, although he was not well. And so they understood what the situation was, but they also understood that he had major behavioral problems, which were starting to manifest themselves on the medical floor as the level of sedation from uremia lifted. And so they conferenced him, and how could they do best by this guy? And they decided, well, there was this kind of special psych unit that had sophistication in medical treatments and illnesses also, which is something we don't have much of, but I'm a big believer in that we should have units like that around the country. But in any case, Bellevue happened to have one. I should say historically, they only did from time to time, but it happened to have been revivified at this particular time. And so the unit chief of that unit plus the unit chief of the medical unit met, and they decided that he would best be served by being on the psychiatric unit with close medical follow-up until everything was in order. And also they were starting to develop this idea, maybe they shouldn't discharge him too quickly, because to discharge him repeatedly out into the community with no follow-up and no structure whatsoever made this a revolving door, that he wasn't going to be out there long. Over the last year, they calculated that he spent well over 6 months as an inpatient at Bellevue because of the recurrent uremia that was so severe and took a lot of the time. So I'm not sure it says exactly, but in what I've written here, but what ended up happening is they managed to convince the Bellevue outpatient dialysis clinic to actually accept this guy as a patient, which for whatever reason had not been done previously. And miraculously, in part because he stayed a long time on the inpatient unit. I was actually in managed care at that time, and people were pulling their hair out about how long the length of stay was and how he wasn't so psychotic anymore and what the heck was that all about. And I told them what it was all about. And I told them also something which we're supposed to be doing. We're supposed to be taking care of people and not just generating units of care that yield money for physicians and institutions. So if you have somebody like this, you keep them longer and try to organize some kind of next plan that will sustain them in the community and in their health. And if that doesn't work, then you reevaluate that. It's like every relapse is a learning experience, and you try to see what was missing, what you could add, but you take more time, because just to send them out, they'll be back very soon, and that really doesn't accomplish anything. So they got him into this unit, and then he was discharged to no housing, no psych care, and no medical care, but to go to the dialysis center. He actually started to go to the dialysis center 3 times a week. And then they're calling me and we're talking about, well, but he won't go up to see the people in the psych clinic in the next Bellevue building. He'll only come for dialysis. So what do you think a sensible solution would be to a guy who's now actually connected to a dialysis program, sits in a lounge chair for 6-7 hours 3 times a week, will not go upstairs or to the next building across the street for his psychiatric visits? How might that be better organized?
Maybe possibly arranging for like a provider to come to him while he's in dialysis, if they're able to. I know that's an extra stretch, but kind of meeting him where he is.
Absolutely. And the way you put it is correct. Frankly, if anybody else is reflecting on the tentativeness with which you said that, and if they're willing to do it, and if they're willing to stretch, and it's really not the breaking point, and so on and so forth. I mean, those are the realities of how our system is structured now. It's very siloed and fragmented. So nobody's going to come from someplace else to someplace else to provide any kind of consultative input care or anything. We just don't do that. You come to us. And that's a very rigid and a model that is outdated or was never really appropriate. Yeah, so the care has to be brought to him rather than expect him to go up to care. There are case reports of patients with severe recurrent major depressive disorder who have actually gotten ECT in their dialysis center because they're sitting there in a medical setting. And if you can orchestrate the appropriate equipment specialist for ECT, ideally an anesthesiologist would be good. But you can actually do serious medical treatments, serious mental health treatments of a very invasive biological variety, for example, in medical centers. I don't say we're anxious to do such a thing in the primary care clinic, but this is actually a quasi inpatient setting, the dialysis center. But it suggests what is possible, even though it's thinking out of the box. And of course, we're talking about simpler things like the mental health provider coming down and seeing how they're doing clinically, and then talking about continuing the treatments, the medications, or changing them, or what have you. Again, I always throw this in ideally involving the family to get perspective on how it's actually going and what the issues are, and align with them to try to do better going forward. But probably the nurses and social workers are the main staffing of dialysis centers, and a nephrologist or so. And they have tremendous expertise and ability to work with people on both the medical side and the family and mental health side. And they're an underutilized resource. So that is what would be called the specialty model, specialty patient-centered home model, where you bring things to the specialty program. So this gentleman didn't require ECT, but eventually somebody who got to know him from the psych outpatient clinic would come down and meet him in the dialysis center, and also would be talking and collaborating with the dialysis staff so that everybody was on the same page about early warning signs, what the treatment should be, what questions to ask about symptoms, and so on and so forth. So it really is possible, but it is not how we operate. But I'm just making that suggestion because taking care of people with both mental health and serious mental health and serious medical problems is a real challenge in our system because of the siloed fragmentation, among other things, and that these are very difficult patients to take care of at the outset. People used to talk about patient-related factors, physician-related barriers, and systems problems. So the patient-related is that they are not organized and they don't follow through, and their communication may not be clear, and they may be all over the place and not focused, and they may be severely disturbed. The physician side is, I want to stay a mile away from that patient. The patient is so odd, bizarre, can't even put sentences together. It's very uncomfortable to speak with them, and so on and so forth. And then we already talked about the systems issues about you have to fit very narrow boxes around a specific thing like your primary care or your HIV or your dialysis. And there's no connections between those boxes and other aspects of the complete human being. Okay, so it is 11:57. I have yammered far too long. In the last remaining, whatever it is, I just wanted to open it up, and I'd really be interested in your feedback about my hour-long yammering, and also anything you wanted to comment on or anything you wanted to bring up. And if I should just say the last thing, I'm not exactly in the schedule right now for e-consults or whatever, but I hope that you will have my contact information. I would be very happy for you to contact me on my cell phone, on email, and we can arrange a time to talk about anything, because I would love to help you. And heck, when we arrange a time, we can even plug it into the MAVEN system, so MAVEN even knows what we're doing. So I'd like this to be an introduction of you to me and me to you, so that, you know, we can go on to have a, as as they say at the end of Casablanca, Louis, this is going to be the beginning of a beautiful friendship. So thank you.
Thank you, Dr. Schwartz. Unfortunately, this is Stanford University's last didactic session with the MAVEN Project. But I love that you are still willing to pass along your contact information and email, just in case anybody does have any questions or that they can pass along to you. That is greatly appreciated. But yeah, you know, it's been a wonderful partnership. MAVEN and Stanford have been contracted for a year, and the contract is coming to an end. And we hope that your session, that you found your the didactic sessions to be valuable. And I'm gonna miss seeing all of you guys every month. But again, you know, feel free to reach out to me if you have any questions about our service lines. Dr. Schwartz has offered his contact information. If you guys have any questions or to bring his way, please feel free to do so. You guys have been amazing.
So what I'm proposing, I'm all about being out of the box in everything. So I gather that whatever the specific tight relationship between MAVEN and your program is ending for the moment. But I would say, insofar as what I said to you, if you have my email address, which I hope they will provide you, or my cell phone, that you will call me MAVEN or no MAVEN. Of course, then I would hope that I would bring you back into MAVEN. But secondarily,
that's a good incentive. I like that.
That I would be the you know, I would be the PR person, or I would be the whatever, the headhunter out looking. But in any case, leaving all that aside, I simply want you to think that I'm available to be helpful, and I'm very serious. And I would really want you to contact me with comments, questions, cases, anything at all. And it does, and I'm very out of the box insofar as I have about 10 specialties. So they could be questions in many realms: medicine, psychiatry, chronic mental illness, addiction, HIV, geriatrics, bioethics, informed consent. I think decision-making is important. Homeless care, so lots of stuff. And I'll tell you if I don't know that thing. But
Yes.
There's a very good chance I can address a really broad range of areas in medicine that you may have questions about. But
before I let everyone go, I just want to say congratulations to the group that will be moving forward in your new position. Again, I'm so proud of you guys. Thank you so much for your participation in our didactic sessions. Please take Dr. Schwartz up on his offer, since again, you guys, you know, there won't be MAVEN Project. You'll have his contact information. Feel free to, you know, tap into as many resources as you can that are available to you guys, and Dr. Schwartz offering his contact information is an amazing addition and supplement. So again, congratulations.
Thank you to MAVEN as well. Sharice, thank you for all your work. And Dr. Schwartz, we will definitely take your contact information. And I can't tell you how helpful it is to have someone to text, call, and just have a quick chat about some of these challenging psychiatric situations that we're in as primary care providers. And they can feel so desperate at times. So to have someone reassure us that we'll get through it, even that can be so helpful. So thank you so much for sharing that. And we'll definitely share that with the residents so they can have that. And even now, but also in their future practice, if that's okay with you.
Oh, by the way, in the future practice too, one of the cases I gave you was a postgraduate primary care resident of mine, and many of them would contact me, you know, building on what we've done during the residencies, or that they knew that I was a ready and open and available resource to them. So I'd like to be that for you as well. And congratulations to all who are moving on and so on and so forth. Congratulations to everybody who's working in and completing this wonderful program. And thank you.
Thank you, everyone. I hope this
Thank
isn't
you guys.
so long for now, I hope. But
That's right.
yeah,
Bye-bye.
we hope to talk to you guys in the future. Take care. And yeah, you all will receive Dr. Schwartz as well as Dr. Abramson's presentation slides later on. And Jessica, I have the information that I've been promising you for the past couple of weeks. So expect that in your email soon. And again, congratulations to you guys. And again, so long for now. Take care, everyone.
Y'all have a good weekend.
Bye-bye.
Bye.